Recording in progress.
Hi everyone. Sorry for being late. I was having some troubles with starting the Zoom. But I promise I'll end on time. So let me just admit the remaining people. Can you hear me?
Yep.
Okay, thank you.
Yeah.
Thank
I
you.
can.
Let me see. Still people coming in. I'll wait for another minute or so, and I'll start. But well, how's everyone doing? Like revision-wise? I'm not sure, but if you have read my recommended book list, it might give you some good references in case you have any questions after this mock, because I did not really provide answers to everything, like detailed explanations to everything. But so if you have any questions, you can still email me or just find the answers from the textbook, which I recommended. But anyway, I think that's it. So people shouldn't be coming in. All right. Oh fudge. Let me see how I can start this Kahoot. Oh no. Oh no. I didn't realize Kahoot needs to pay to say up to 100 players. Did they change that? Well, we can still just talk through the whole thing if that's fine. But let me see. Fudge. Okay, this sucks. I didn't think to test the Kahoot. Do you mind if we just discuss it like this, and then I'll show the answers, and I'll reveal the answers and explanation instead, because the Kahoot does not support more than 10 players right now. Yeah, really sorry about that. Oh, it used to be so good before. Sorry. Okay. Okay. So before I start, just a few words. I was going to briefly summarize the things, but something to keep in mind is that the thing that you need to learn about is still the same: physiology, anatomy, and pathology. So Sem 2, there were like 90 questions on these three areas, but then take a look at Sem 3. You will get the PowerPoint if you fill in the feedback form, which I'll provide after the session. So in Sem 3, there is considerably less questions for these three main areas because there's a new area, mainly pharmacology. there are so many pharm questions about like those antipsychotics, general anesthesia, and all these stuff. And they are just really hard facts. So there are not a lot of tips to give you. But then something you need to really read about apart from these three main areas are the pharm stuff. Okay. Okay. Yeah. Sorry, I can't really do the Kahoot. But yeah. Okay. So first of all, maybe you guys can try typing the answers into the chat box or something, just to like know what everyone feels, and yeah. And if you have any questions, just feel free to type into the chat box. This is a very free session. Okay, so quiz 1. I'll give around 20 seconds for each question. You guys can actually just read it. Like, during which stage of pregnancy is the fetus most susceptible to teratogenesis? 3 to 8 weeks. Any more answers? Oh, I thought the chat hit it. Okay. Wait. Just let me. I'll just. 1 second. Yeah. I was trying to hide it with the chat box, but didn't realize that it doesn't appear on your screen. Okay. You guys can't see it right now, right? But anyway, okay, I guess that answer was shown already. Oh, it's so cold. I'm like, my teeth are chattering. Okay, so one very good textbook about embryology I would recommend. Having a brief read. You don't have to read the whole thing. But maybe at least read the first few pages. There are some pretty beautiful graphs on these stuff, and they're pretty important, including this chart. So it lists all the important developmental stages and the events that happen by the week, because that's how they test you. They will ask you something that happens in some X week or something, and they'll ask you if it's true or false or stuff like that. So I've highlighted some which you can read up on later. But anyway, for teratogenic susceptibility, the pregnancy stage basically is divided into 0 to 3 weeks, and then the 3 to 8 weeks is the embryonic period, where the organs have formed but are still developing, and then the 8 to 38 weeks where it is just growing. So teratogenesis is most likely when it is 3 to 8 weeks, because in 0 to 3, the baby just dies instead of having some teratogenesis. It is more susceptible to high lethal rate. Yeah, and in the 8 to 38 weeks, since the organs are already developed, they are just growing. So teratogenicity is actually less common. Well, yeah, that's question 1. I better hurry up. Cover the answer. Okay, when does neurulation occur? Oh, by the way, these are all, well, don't tell the faculty that I said this, but then, well, some medical student apparently memorized like 90 questions after his, well, or her semester 3 exam. So these are all exam questions. 3rd week, any more answers? Come on, be brave, people. 2nd week. Well, think, when does neurulation stop? Like the anterior and posterior neural pores, when do they close? And then move slightly previously, like before that, and you'll get around the time. 4th? Okay, well, the answer is end of 3rd week. So, sorry, my teeth are chattering because it's so cold. Well, neurulation. Here's the chart from Langman, which I recommend you having a read. It begins at like around day 19 to 20. So, yeah, that's week 3, and it ends at week 4. Yeah, it takes around 1 to 2 weeks to fully take. Oh, it's fine. You will get, okay, I'll set up the Kahoot for you to practice afterwards with your friends because uh, I promised you a Kahoot, but I can't deliver it right now. But yeah, just fill in the feedback form and I'll send everything to you. And also these are my notes which I wrote before. I'll also send that out afterwards. Okay, question 3. Oh, just have you guys have a look at this question first. I better get a jacket or something. This was like literally the first question in my exam. They always like putting the most difficult question somehow in the first question to throw you off or something, scare you. BMP4, yeah, I put this into the Google form. Oh, so cold. Okay, yeah, it's BMP. So I'll just briefly explain about it. So neural induction, mainly there are two main molecules or signaling stuff, FGF and also BMP4. So FGF is increased while BMP4 is inhibited, and FGF will increase, which will further lead to coordinate noggin increase, which are all very important later. Do you need to know about the Glee SHH cascade? Well, I didn't. Well, I can't say you don't have to, but then it didn't. I don't remember seeing this in exams. So, well, to differentiate whether it's something is high yield or low yield, one way to think about it is the clinical significance. So if it is very clinical significant or there's a lot of relevance in the future when you practice as a doctor, then probably it will be very important to learn about it. But of course, the nitty-gritty stuff usually takes a lot of time to memorize, and there are a lot of other easier topics, mainstream topics that you can better familiarize yourself with before going on to these details. But anyway, this is also from Langman textbook. I've highlighted some important things. So upregulation of FGF inhibits BMP4. There are some important molecules like noggin, chordin, and follistatin, and these stuff. And these are the main things that you should know. Mainly, yeah. And also the things in your lectures, of course. The lectures are your backbone, and you have to add the meat to it, like by just books and stuff. Don't ask me if I read Jaffa. I did not, so I cannot really tell you if it is good or not for this semester. Question 4. Closure of neural tube. Why is it so cold? Okay. Cap. False. False. Okay. Yeah, it's false. So closure of neural tube occurs at the middle, like in the middle of the tube. Let me show you the picture. It starts here. Okay, I hope you can see my mouse. It starts at the middle and then moves cranial and caudally, and forms the anterior and also posterior neural pore. And the dates of the closure of these two holes are very important. So please remember these: day 25 and day 28. I'm not sure if they tested in semester 1, but if they did not, they probably will also in semester 3. Yeah, very important. It's so cold. Let me move on. Okay, which of the following sequence is correct? So this is basically overview of neuralization process, and you should really be familiar with that.
Yellow.
Just A, B, C, D. You can just type. Second one, yellow. Groove fold tube crest. All right. So according to Langman, it is the groove fold tube crest. But I understand if, well, according to the PowerPoint, sorry, the lectures you have, it is groove fold tube crest. Oh yeah, I intentionally like uncovered the answers. Yeah, so I won't blame you if you got like the groove and fold by like mistake because they actually happen together. But then it is obvious. You must know that it's the groove and fold, and then it forms the tube, and the neural crest cells come out. here. So this is taken from a lecture. So first there's the neural groove, and then the sides come up, forming the crest, forming the folds, and then they merge together to form a tube, and then the crest cells, which are originally part of the fold, will migrate downwards. Yeah, this is the basic gist. Also the details are in the notes, which I'll send out. Yeah, you will definitely be able to practice this Kahoot. I'll send it out to you guys. Don't worry. Really sorry that I can't host a very big Kahoot session because I did not pay for that. Okay. Question 6. Oh, I spent so much time typing this Kahoot. Okay. Signals for somatic differentiation. This is also important because clinical relevance for what's that called? Oh, never mind. Anyway. Notochord chord. Neural tube. Mainly A. Well, you're all correct because signals come from everywhere. But then something you need to know about probably is what signals they come from. Here. So signals for somatic differentiation arise from all the surrounding structures like notochord, neural tube, and all those. So they probably won't ask this, but then maybe you need to know like the molecules that are important, including SHH, noggin, and also NT3. These 3 at least. Yeah. And so neurulation and also the somatic formation are very important because the timing needs to be coordinated. Otherwise, there will be like structural abnormalities like what you've learned in case 1, spina bifida and all those. So if the timing is not right, the baby suffers. And about somites, more details, you can screenshot it or I'll send you the PowerPoint later. These are just all taken from my notes and also from Langman, the embryology book. So basically it's from mesoderm, germ layer, others just, well, a somite forms sclerotome, myotome, dermatome, like basically everything that you can think of. Don't bother too much with the nitty-gritty for somites, but maybe at least know about it. Yeah, I'll send you these notes later. So case 1, you also need to know about the rate of growth of the spinal cord and also the vertebra, and that's why it's also very clinically relevant because of the lumbar tap. So make sure you know about that. Just read your anatomy workbook and you'll be fine. Okay. Question 7, differentiation of the brain occurs from the swelling of the 3 primary vesicles at the neural tube at the 5th week. Is this true or false? Oh, and if you find the pace too quick or too slow, just let me know. True. True. Some say false. It's true. And this is a very important topic. So how your brain develops is from the 3 vesicles, the 3 primary vesicles, the proencephalon, the mesencephalon, and also the rhombencephalon. And these will turn into the forebrain, midbrain, and hindbrain. And what you must know is what is this basically this. So telencephalon will differentiate into something, the cerebral cortex, diencephalon, thalamus and hypothalamus, mesencephalon is midbrain, metencephalon is pontocerebellum, and the rest of these are all very important and testable in exams. Oh, and please keep in mind that this is a sort of a revision session, but it is more to bring your attention to the key areas that they would like to ask in exams. So forgive me if the explanation is a bit short, but yeah, otherwise we can't cover everything. Okay, question 8. Which of the following is wrong? I just showed you that table, and I hope you memorize these. Very factual stuff. B. Yep. Metencephalon is not the midbrain. It's the pons and cerebellum. The myelencephalon is the medulla, and the mesencephalon is the midbrain. Yeah, just remember this. It's quite hard facts. So before we move on, just keep this picture in mind because it will help you later in the following question. Oh, can you see the question? Oh, you can't. Okay, which part forms the thalamus? A, B, C, D. Oh, you can see the answers. Never mind. It's basically C, this part here. So another important thing is to know your flexures, like the pontine flexure, all those stuff. A is obviously the telencephalon, which will differentiate into the cerebral hemisphere. So, and then it's like basically according to this flow. This is the telencephalon is most caudal. The myelencephalon is most the telencephalon is most cranial, and then the myelencephalon is most caudal. So just deduce. So the diencephalon is around there. So yeah. And more things you should know. There's just a mini checklists. Are these stuff? Just have a screenshot or something. CSF clearance is like, you need to know where are the choral plexuses because that also appeared in my exams. You need to know which ventricles these plexuses are. And then it goes through the lateral ventricles, through the cerebral aqueduct, and all those stuff. Got that? I'll move on. That's case 2. Really sorry that we can't play the Kahoot. Okay, case 2. It's around like 10 questions per case that I've prepared. So WHO and a pain ladder, which was originally for cancer, but anyway, which drug should be given next if NSAIDs and paracetamol don't work? Come on, guys, it gets boring if you don't answer. Tramadol. Yeah, NSAIDs and paracetamol are step 1. So if these don't work, we would move on to step 2. And those are the weak opioids, including tramadol, codeine. Oh, did I also put codeine? Oh, yeah, codeine is also a weak opioid. Tramadol is also a weak opioid. So these are all okay drugs to be given as a step 2. And then the strong drugs would be morphine and all those things. One thing to keep in mind that if it is a chronic pain, then you would step up. However, sometimes you need to step down in acute pain settings because, like, imagine if you got your leg amputated or something, you would need some strong painkillers to stop the pain first, and then gradually taper down the dose and move down the steps. So in a chronic setting, you would move up, but in an acute setting, you might sometimes have to move down instead. Yeah. And aspirin is NSAID. Respiricase. I forgot what respiricase is already, so probably not important. Haha. Okay, this appeared in the Google quiz already. What receptor superfamily does? Yeah, G protein. I won't talk too much. So some important molecules concerning the pain pathway would include substance P, bradykinin, glutamate, and possibly histamine. So glutamate is important because of the A delta fibers, while the rest are very important in C fibers. I hope you know these, like the slow pain and fast pain. Some of the key rules to remember is that decussation always occur in the second order neuron. And another tip I would recommend is to find a good picture which helps you visualize where the decussation occurs. So once you remember where it decussates, then you can deduce, oh, at the spinal level, maybe the dorsal column is still a first order neuron, because that's something very easy that they could test in the MCQ. Yeah. So these are more pictures. If you want more details, there's a book called Neuroanatomy by this Haynes person. I won't really recommend it unless you are really interested in neuroanatomy. But anyway, a brief overview of the pain pathways, because of the ascending tracks, because a lot of people have told me to tell about it. So basically, dorsal column is for fine touch, proprioception, and all these stuff. But before I start, do different sensory fibers have different neurotransmitters? Yes, they do. So what I mentioned just now, substance P especially, is for slow pain, the C fibers. Glutamate is quicker, is ionotropic. So it's quicker and it's used in like A delta fibers. So different sensory fibers do have different neurotransmitters, but as your case is mainly concerns pain, then these molecules will be the main things that you should know. The others I won't bother too much about it. It's not worth your time. So there are many types of sensation: fine touch, two-point discrimination, proprioception. These are dorsal column. The pain, temperature, crude touch are anterolateral system, and the other things like unconscious sensation are by the spinocerebellar tracts. So something very important is about the Romberg sign. So a lot of people often mix up the Romberg sign positive as a spinocerebellar tract lesion, but in fact, it is actually a sensory ataxia, which I'll talk about later. So first of all, dorsal column is for proprioceptions, and it decussates at the medulla level. So it continues upward first, and well, it's not really a mnemonic or anything, but I just remember cuneate, and then gracilis, and then cuneate. So basically, cuneate is on the outer side, and it helps. I don't know, it might help you remember it. So anything below T6, like the lower limbs, it will travel in the middle, more medial part, which is the gracilis part, and anything above T6, cuneate. Yeah, so this is basically the most important things that you should know. And the dorsal column and anterolateral systems all terminate at the thalamus, at the ventral posterior nucleus. This is also very important. So anterolateral system, pain, temperature, crude touch. Well, substance gelatinosa is quite important. I hope you'll remember this term. Also, they decussate immediately at their current level, spinal level, and then move upwards. So that's the main difference between it and the dorsal column. And as the name shows, anterolateral tracts, the tract is in the anterolateral part. This might not seem very important, but when you reach clinical years, there are many spinal lesions that occur at different locations, and it helps you if you have a diagram like this in your head. So, if it's a syringomyelia, which starts from the middle, then you will know what tracts are affected first. But anyway, this is not really relevant for your semester 3, but keep in mind anyway. Then the spinal reticular thalamic tract is less important for exams, but still important because it's for arousal and emotional parts of sensations. One thing to keep in mind is that it does not terminate at the VPN, the ventral posterior nucleus, but it terminates in the intralaminar and posterior groups of the thalamus. Yeah, just this is the only thing that you should know anyway. So let's move on to the quiz. True or false? Fast shooting pain is by A beta fibers. False, false, false. Yes, you're all right. Yeah, A beta, A alpha, these are very thick fibers. Just remember that pain is actually transmitted by very thin, sometimes unmyelinated nerve fibers. This is very important because that's how local anesthesia works. And anyway, A beta is more like touch and stuff like that. So fast-shooting pain is by A delta fibers. I think I put a chart here. Yeah, this should be something from your lecture notes or something. So just make sure to memorize that slide. And with the decreasing thickness, like from A to C, C has the C is the thinnest fiber and unmyelinated, so it has the slowest conduction, and so it carries the slow pain. A delta is a bit better because it's a slightly thicker and it is myelinated, so it is carries the fast pain. Yeah. Let's move on. If you have any questions, feel free to type into the chat box anytime. Beta fibers, beta fibers, beta fibers. Yes, beta fibers. This is a gateway theory of pain. Well, I think that's the name. Let me show you the diagram. This is taken from Bare Neuroscience. All the recommended books I have put in the Google Drive. You can just look at it. Anyway, the theory is that by rubbing the areas near where your pain is, you will stimulate the thicker axons, the A beta mainly, which will actually stimulate the inhibitory neurons that inhibit the pain neurons. It might seem a lot, but just look at this diagram a few times and you'll get the understanding. So again, rubbing will stimulate A beta. A beta fibers will stimulate some inhibitory neurons that inhibit the pain pathway. Okay? Yeah. Let's continue. This is a very classic question that is tested everywhere. So loss of proprioception and vibrational sense. First of all, think what tract this is, and then where the lesion is. Has it decussated or not? Any answers? I don't see any answers yet. C. Any more? Should I wait? Green. D. So it's basically, well, we can first use elimination. Proprioception and vibration sense, obviously, dorsal column. So dorsal column terminates in the thalamus, specifically the VPN, ventral posterior nucleus. So obviously ventrolateral is wrong. And then it leaves us these. And then it is a pons lesion. So the pons is higher than the medulla, and it already decussated. So if you think, you'll finally arrive at C. See you, Louis. Okay. Yeah. So very classical question. I'll just show you the thing again, so you can visualize. If there's a lesion in the pons, let's say this is the left side lesion, it would cause a right side proprioception loss. Yeah. Okay. Any volunteers to answer? This is becoming a one-man show. I'm sad. C. Green. It doesn't matter if you're wrong, like no one cares. Okay. Yeah, it's C. So same logic as before. You lose your right side proprioception, which is dorsal column. It is in the lower extremity. So lower extremity below T6, it is in the medial side, which is the gracilis. So the cuneate you can automatically just remove. The spinal trigeminal is more for the face, so you can also eliminate. oh, I like eliminating stuff, so that's how I like tackle the MCQs. And then it leaves you with the right or left. So if there's a right proprioception loss in the lower extremity, which nucleus has lesion? Well, it would be the right because it decussates after reaching the nucleus in the medulla. Anyway, let's continue. If you have any questions, just let me know. Which of the following statements is wrong? Spinothalamic tract has collaterals terminating in the reticular formation. Spinal reticular tract. Why is it left gracile? Just go back and look here. So, sorry, let me just answer this question. Someone asked, why is it the left gracile? So let's see here. Lumbosacral level, which is like lower limbs. Let's track this red line, if you can see my mouse. Let me enlarge this as well. Okay. Continues upwards without decussating until it reaches the medulla, the nucleus. And then, after reaching the nucleus, it moves on as the second order neuron and decussates. Okay? So before the nucleus and at the nucleus, it is still ipsilateral. After the nucleus, it becomes the second order neuron, and so it decussates. Does that help? You can maybe take a look at this. Okay, yeah, understood. Okay, yeah, let's continue. Which of the following statements is wrong? Green. I hope you didn't see my answer just now. Anyway, yeah, green is green. Yeah, dorsal column 5. Let's tackle it one by one. This is true. Spinothalamic tract has some collaterals terminating at the reticular formation. It helps convey the emotional side of pain. Spinothalamic tract and medial lemniscus terminate somatotopically in the VP nucleus. The VP nucleus is at the thalamus. That is true. Somatotopically means that they still did not mix. I hope you understand that this keyword. I can't just sort of. Oh, yeah, this is true anyway. Dorsal columns of the lower limbs are more medial than the upper limb fibers. So again, back to this. If you think about it, CGGC, just remember G is below T6, and that's all you need to know. But if you try drawing out the lines, let me see if I can draw here. Okay, let's draw. Medial lemniscus and the dorsal column is the same thing. So it just basically continues as a medial lemniscus. Yeah, okay. So these are the nerve fibers. Do you see what I'm doing? So this is the correct one. So a wrong one would be so if the lower limb fibers are traveling in the lateral parts, then the upper fibers that travel in the medial part, this is wrong by the way, it will have to cross and it would cause a lot of tangle and a lot of mess. So that's how I remember it. But if you remember this flow, it's also so much smoother. Well, that's how I remember it. Hope this helps, but yeah. Or you can just memorize it the hard way. Anyway, reticular formation neurons do not project to the VP nucleus, it projects to the intralaminar nucleus of the thalamus. Okay, easy question. 17. Pain reflex arc is polysynaptic. True or false? True, 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 false, true. Okay, most of people say true, and that is true. I'll just show you the diagram here. 1, sensory neuron, a lot of interneurons, and then finally the motor neuron. Because when you touch something hot, something sharp, something painful, you need to contract. So obviously you will have to have at least, one synapse, but then there are also multiple inhibitory neurons and also new relay neurons that also go up to the brain. Oh yeah, it's not the stretch reflex, it's the pain reflex. Where yeah. So yeah, just keep this in mind. Okay. As I said, any questions, just feel free to type into the chat box. It would be better if you just type it publicly because I don't have to read more. Anyway, question 18. We need to pick up the pace a bit, or otherwise I can't show you all the questions. So please answer quickly. It doesn't matter if you're wrong. I don't know you guys anyway. See anymore. Come on, just type a random answer. C. Okay, yeah, it's C. Do you want explanations actually, or are you just fine with me showing the answer and just moving on? Because we don't have a lot of time, but I don't mind actually. I can go as late as you guys want. But anyway, okay. Remember this: second order neuron always decussates. With explanation, okay. Dorsal column neuron and meniscus always decussates at the middle level after it reaches the nucleus. Okay. 5 is carried proprioception from lower limbs travel in cuneate fascic. Cuneate is wrong because that's the more lateral part of the dorsal column, and that's the upper limbs. Fasciculus gracilis carries first order neurons. Fasciculus are all first order neurons. Can you get the feedback form at 4 if you end up running over in case we need to leave? I will send you all the feedback forms provided that you have filled in the pre-mock quiz. I haven't closed the pre-mock quiz yet, so you can still fill it in. I will send out the feedback form to the email addresses afterwards. Yeah. Okay, 19. This is case 2 now. We're moving on. Oh wait, we were already case 2. This is pharmacology already. Pharmacology, just type some answers, please. Yeah, okay. I'll explain more if it's complicated, but if it's just some hard facts, I'll just leave it up for you to read on. False. Unfortunately, that's true. Yeah, so for myelinated nerves, you need to have at least 3 consecutive nodes of Ranvier. Yeah, that's basically it. So the details of the general and also local anesthesics are really important, and you need to know how they work, the mechanism of action. I don't have time to cover it, but any textbook or lecture will give you enough information. Let's see. Yeah, so analgesia and anesthesia are also things that you should need to know, like how to differentiate. And about local anesthesics, one thing to keep in mind is that, well, 2 things. Often vasoconstrictors are used together because it decreases the absorption rate by causing vasoconstrictor. Because this is a local anesthesia. The anesthesia is meant to remain locally so that it does not enter the systemic circulation because it will cause side effects, and also the anesthesia at the local site will be diminished. So vasoconstrictors are very useful. However, remember that cocaine can never be injected because of the symptomatic properties, whatever that means, I don't know. But just remember that. And cocaine is also a very potent vasoconstrictor. So if you inject it, it is very potent. So it's always used only topically. Okay, which local anesthesia is less toxic? You can actually deduce it. Like, which name do you always hear of? Which drug do we always use? Lido. Yeah, Lido. Obviously not cocaine. Bupivacaine is the most toxic local anesthetic. Just, well, there's something good to know, but, well, just remember lidocaine, safest. Okay, paracetamol. Before, okay, let's move on. False, true or false? True, false, true. Okay, this is worrying. This is not true. Please, this is not true. Here. So paracetamol is not an NSAID because it is not. Let's see here. It does not have any anti-inflammatory effects. So it's not an anti-inflammatory drug. NSAIDs mainly refer to the COX inhibitors and aspirin. And paracetamol is in a league of its own. It is not in any class, even in Ragandell. It's just paracetamol. So it has analgesic and antipyretic effects, but it is not anti-inflammatory. So please remember this. This table is in the Google Drive. Also my notes. You can just have a look. Yeah. Okay, back to the pain ladder. I mentioned this before. Let's hurry up, guys, please. Can I share the Google Drive again? Yes, okay. After filling in the feedback form. C, morphine, yes. Why? Because this is an acute setting, very painful. So we need to give something strong to first stop the pain first. So that's morphine. We don't start with paracetamol. Okay. Side effects about NSAIDs. Very important clinically. Exam-wise, maybe less so, but clinically it's very important. Napro, naproxen cannot be given anymore. No more. Okay, Sophie, you're the star. Yes, you are right. Diclofenac is the most safe drug, the safest NSAID. Naproxen, it is contraindicated in old patients and also in those with poor renal function because it is cleared by the kidneys. So anything that's cleared by kidneys, like ibuprofen, shouldn't be given when the patient has poor renal function. Okay. Colchicine is a DBARD for treating gout. Probably you don't need to know yet. Okay, 24. A. Yay. You're right. Codeine is a mixture of cocodamol and also morphine. Morphine is a very strong mu agonist, by the way. Okay, so codeine, that's why people get addicted to cough drops. Like there's codeine. Yeah. Continue. Tramadol analgesic effects is from its weak mu agonistic properties. False. False. True. False. Let's go back to the PowerPoint. Tramadol, it is a weak mu agonist, but that's not like the mechanism of action. It mainly inhibits monoamine reuptake. Okay, so it is an opioid, but it does not work in the usual mu or kappa receptors. Yeah. So about opioids, there are weak opioids, codeine, tramadol. There are also strong opioids, morphine, and the mechanisms mainly of these opioids, only like mainly of these opioids, but like other opioids can bind to kappa receptors and all those stuff. Some also bind to serotonin stuff. Some like affect the monoamine like tramadol. But mainly it binds to mu receptors, and well, basically has two sites of action at the medulla and also at the spine. Yeah. And the side effects include respiratory depression, which is very important because the patient can die. Constipation is also very common. So we sometimes give laxatives. Yeah. More stuff to know here, allodynia, hyperalgesia. These two are very different terms, but don't mix them up. You should also know when they appear, in what types of situation, because they can easily give you a situation and ask you, what type of pain is this? Yeah. Okay, let's move on to case 3. The eye. So I have previously given a lecture on case 3. So if you have any questions about case 3, you can just go and look at this slide, 100 slides. very lengthy, but if you understand all of it, I promise you will have distinction, at least for the case 3. It covers everything you need to know for physiology and anatomy. Yeah, just go and have a look when you have time. Anyway, let's continue. Case 3. Left nasal and right temporal vision loss. Where is the damage? So just to juggle your memory, and I'll show you now. Optic tract. Something optic tract. Right optic tract. I like you. Right. A tract. Yeah, the tract. So a lot of people seem to be struggling with these types of questions, but actually just memorize this diagram and you will literally understand half of the exam questions they throw at you for case 3. So how I like approaching these questions is, first of all, left nasal and right temporal. I would first visualize these circles. Left nasal and right temporal. So it's this one. Okay. And then I would think, it's actually just there's only 4 scenarios that they will ask you mainly, and you can just match it back. So a better diagram might be helpful. This one, like the different colors help you differentiate it. You can have a look later. But that's it in how you approach these questions. Yeah, these are from your lecture slides. Before we continue, some people also asked me to cover a bit on case 3, like some short summaries or some important things. Frontal eye fields, like read about it slightly. It appeared in one question in the exam. Hard facts, this is very important. It appears in the anatomy questions. It appeared in my exams, so make sure you memorize these. The differences between rods and cones, these are the 5 main differences, and you should know the details for each of these. This is in the teaching slide that I uploaded to the Google Drive. You can just have a look. And some were also asking about the phototransduction pathway. You don't need to know this, but make sure you know the difference between cis and transretinal. That's all you need to memorize. Well, probably. Well, I can't guarantee, but yeah. And these are also very important, but the 2 main rules is this one. So just have a screenshot or just revisit this PowerPoint later when you are revising. I'm not really giving you all the facts because you should have prepared your own notes or anything. And this is basically a diagram that summarizes all the scenarios. And you can have a look later. Let's continue with the questions. You don't have to really know about, is it worth learning the color fields of the ganglion cells? What do you mean by the color fields of the ganglion cells? Like, you need to know at least the M-type, P-type, and also the non-M, non-P ganglion cells. Red, yellow, green, blue. Center and surround is very important. You must know that. But then for red, yellow, green, blue. Well, the center and surround theories are the same. Like no matter it's dark, light, like dark or light, different colors, it's all the same. Once you understand the concept, you should be able to deduce it. What are the different types of ganglion cells? Oh, this is very important. You must know it. But let me show you the question answer. Yeah, it's multiple rods. You don't have to know about the type of ganglion cell in this question actually. Dark and light contrast. First of all, dark and light. It obviously it should be rods, and then multiple or single. Well, you need to know a bit of the M type. M type has a very large receptive field. And how do you get large receptive fields? You need to have a lot of cones or rods, and so the answer should be probably multiple rods. Let me show you a slide I took from my own teaching slide before. Did I put it here? Oh, I did not. If you have any questions, just go and, for this case, you can go and have a look at my teaching slide in, oh, did I put it here? the type of ganglion cells, P type, M type, and non-PM, non-M. The properties of these ganglion cells are important. I recommend you having a look, either in the Bayer neuroscience book or in my teaching slides. Sorry, we don't have time to fully cover everything. I'd rather you try out all these questions first for your own benefit. So question 28, nystagmus. Is this true or false? False, yes. What's the correct term for this phenomenon? Anyone know what's the correct term? Astigmatism. No, sorry, that's not right. Saccadic, yes. Sophie, okay, you're the star. Okay, saccades. Saccades is very important. You must know the difference between nystagmus and saccades. Basically, this is the saccades. When you see something that you like an object of interest, you will want to bring your eye to there because so that the image is shown onto your fovea. So high acuity. So that's the case. Nystagmus is like when you're on a train, you're looking out. How do we assess your teaching slides? I sent out the Google Drive link before. I will do it again along with this PowerPoint. Once you fill in the feedback form. Yeah, please stop asking. Okay. Oh. Yeah, see you. Oh, okay. Let's see. 29. 20 to 1. Yes, this is a very important, but something that I got wrong in exams, I think. Well, or maybe I guess right. Yeah, C. It's obviously not 1 to 2, not 1 to 50. And congratulations, James, you actually know something. Yes. Oh, by the way, like in case you were scared after doing the pre-mock quiz, this is the mark distribution. So if you scored like 6 points, you're already above average. So don't stress too much about it. Yeah, okay, back to the real Kahoot quiz. Yeah, this is just very hard stuff. I won't explain it more. This is for otitis media. B. Any more? B. Yes, B. Do I need to explain? I think I did provide. Okay. Yeah, B. Asians. Well, not everything is related to Asia. High social class, it should be poor social class. This is obviously just me running out of multiple choice questions. Down syndrome, because sort of the ear canal or something is shorter or something. I forgot. But anyway, it's Down syndrome. You can not really important, but just know about it. Okay. Hyperacusis. What is the cause of hyperacusis? You should know this by your OSCE examinations. False. Yes. Which nerves? Which are the right nerves? Yes, 7 or 5. The nerve disobedience are also the other one which I forgot. Anyway, haha. Yeah, it's false. Yeah. Yep. Okay. You all got that. You all got that right. Stria vascularis. By the way, if you are uncertain about something, would like to have a quick explanation, then just let me know. Otherwise, if I judge that it's not too important or just hard fact, I won't explain. Any answers? This is quite complicated. D. Green. Okay, so the important things about this topic, like endolymph, perilymph, is you need to know about the potassium concentrations because that's very important. You should also know where is the perilymph, where is the endolymph, and where they are produced. And you probably, yeah, that's probably the most important things. And yeah, stria vascularis produces endolymph, which is also known as Carpus fluid, and flows into the scala media. And it is rich in potassium, not sodium. That's very different from other cell contents. Okay, these are just hard facts, so just continue. autoacoustic emissions. So first of all, you need to know what these are. This is a very long topic, so you basically have to read it up yourself. B. False. Okay, Sophie, are you going to get distinction or something? You seem to get everything right. Okay, yes, false. If you have any questions, I suggest you reading bare neuroscience, because it's a very long topic. Okay. Moving on to the next case, stroke. This was actually so easy that I thought I was having something wrong. Can I explain the last question? Maybe after we cover all the questions, if I have time. Sorry. Yes, it's B, dysarthria. Okay, left internal capsule. What does it contain? Actually, it contains everything that you can think of, including the ascending and descending tracts, the cortical spinal tracts, the pain tracts, the proprioception tracts. All these stuff are in the internal capsule. They're just in different areas, like the anterior and posterior limbs. I suggest you at least knowing like where the tracks are in terms relative to the limb, the anterior and posterior limb, and also like the general of the internal capsule. These are like pretty important. So damage to the left side, so there's no decussation yet. So probably after decussating, it will cause right side motor weaknesses. Okay. The consensual reflex and hemianopia. Just think back to your like to this tract. Where is the internal capsule? There's no internal capsule. Okay, internal capsule is not involved. So that's why I was saying that this question was so easy that I was wondering if I got it wrong. So that just leaves dysarthria, slurring of speech, which I'm currently having right now because my nose is all blocked and I don't have water. Okay, let's move on. 25. Bacilla, yes. This is too easy. Let's continue. GCS. They really tested me 2 questions on GCS, not kidding. False. Any more? I'll give you some time to think for 36 and 37. I'll just go get some water. Sorry, I'm back. Okay, it's true. Well, I don't need to explain. Probably. Oh, is it worth knowing every step of GCS? Yes, unfortunately, yes. There was a pretty good YouTube video that I used before. There was some mnemonics, but I forgot anyway. But this is very important because clinical relevance. This is very high yield. You will need to know it when you reach clinical years, when you graduate as a doctor, and so really worth memorizing all of this. Yeah. Back to the case 5, case 4. I put this mind map, basically the pathways of the hearing into the Google Drive as well. Please take a look. This is very important. The most important things are like you need to know that there are dorsal and ventral cochlear nuclei. You receive input from the spiral ganglion. Please mute yourself. Sorry. Spinal ganglion. So go to this cochlear nuclei, and the ventral cochlear nuclei will decussate through the trapezoid body. This is also very important to the superior olivar nuclei. I'm just throwing the keywords at you, so you must know. Okay. So the superior olivar nucleus goes through the lateral meniscus to the inferior colliculi, to the medial genicular nucleus. The lateral is for the vision, and then finally to the primary auditory cortex. Okay. So this is the main pathway that you need to know for the neuroanatomy wise. You will also need to know about the outer hair cells, how there are efferent motor neurons. Let's see. Yeah, basically everything in this slide is important. Okay, let's continue. Back to the GCS, and this is also false. It should be abnormal flexion or something. Yeah. Okay, this is another question which I'm uncertain about because I was uncertain when I was having the exam, so I'm not sure if I recorded this question correctly. Anyway, patient have these following symptoms. Oh, by the way, one very useful tip in tackling the MCQs in exams is to differentiating which case this is. So they like they're really kind to us. They put the questions case by case, so they won't mix it up. So this was between case 4 and 5. So I'm not sure if this is related to stroke but it should be related to stroke. Sensory neural loss, left hemiparesis, exposing right teeth more. This is actually a trap because it means actually left side facial weakness. And dry eyes could be due to facial nerve or eyelid problems. So I like using. So do you guys have any suggestions for the answer? If not, I like using like just elimination, not parity, definitely. A lot of you are saying A. Yes, I'm struggling between A and B. I haven't revised neuroanatomy for like 2 years. But it's definitely not CDE. For A and B, I'll leave it to you guys to like just discuss on your own. Haha. Okay, let's continue. Oh, and back, like the internal capsule question, it's actually a lacunar stroke syndrome. And it's a very classic presentation of these stuff. Or just yes. Okay. Let's continue. Pharmacology, glucocorticoids, mechanism of action. This is unfortunately something that I did not cover in the lecture, but it is actually very important. It is in every textbook that you can read on. I recommend Rag and Dell, by the way. Blue, A. Okay. Phospholipase A2. Immunosuppressive, because I have a question afterwards about anti-inflammatory actions, okay? But for immunosuppressive effects, it's mainly reducing the synthesis of cytokines. So neutrophils can't go there, reduce all this stuff. Remember it. It's just hard facts. I won't explain too much. Okay, now this one. Anti-inflammatory actions are due to which of the following? A, B, C, D. Very important. You must know with it. B. By the way, annexin A1 is also known as lipocortin 1, in case you read another textbook with another name. It's the same. B. Yes, it's B. Okay, let me have a quick explanation. So glucocorticoids, there are two main actions: genomic, which means that it affects the genes, and non-genomic actions. So the main thing you need to know is that it induces, it increases the concentrations of annexin 1 or lipocortin 1. Okay, very important. Also inhibits PLA2, and yeah, that's it basically. Very important hard facts that you should know. Okay. The patient has multiple sclerosis, gradually worsens, never improves. What type it is? D. Yes, primary progressive, very easy. But then they can also give you other scenarios. This is not what appeared in my exams. I just tweaked it slightly. They asked me another one. So just make sure you know all, like memorize the graph and then you can just deduce it. Okay. False. True. It is true. I got this wrong in exams. Here, this is a screenshot. Up to 90%. I know, I thought it was 70. Apparently it says 90. Are you still taught by Talbot, Peter Talbot? Really nice guy. And his lectures are very important because he sets the MCQs. Make sure you like memorize everything. Well, all the important key facts in this PowerPoint. Yeah, his lectures are very important. Make sure you know of it. Yeah, so, well, okay. Moving on to Parkinson's. This was actually a trick question. This is very tricky. A trap. A and D, okay. Well, to those that said A, you are right if this question is about Parkinsonism. However, Lewy bodies are not just solely confined to Parkinson's, but they also appear in Lewy body dementia. The correct answer is SNCA, SNCA. Let me explain because this is quite important and also clinically relevant. So this is from Robbins Basic Pathology. This is good, very good read. I suggest you read it. Parkinson's disease, neurogenic. So some useful mnemonics is TRAP. This is the presentation: tremor, rigidity, achalasia, postural instability. By the way, forgive me for my nasal voice. It's very cold here. Yeah. So TRAP, and then the genes. So Parkinson's is actually a familial Parkinson. It's not really common, but the genes are LRRK, which a lot of you chose, and also Parkin. However, the question is asking about Lewy bodies, which is alpha-synuclein, and the main gene that encodes it is SNCA, probably synuclein alpha or something. Yeah. So alpha-synuclein or Lewy bodies appear in both Parkinson's and Lewy body dementia, but these are two different disease entities. Very important in geriatric medicine. But the main difference is that Lewy body dementia, there's dementia arising within 1 year of the onset of motor symptoms, while Parkinson's is mainly a motor dysfunction that later, after many, many years, almost decades, will start having neurocognitive decline and all this stuff. Yeah, hope you understand. Dopamine agonist activity in the tuberoinfundibular pathway causes which symptom? A. This is, yes. You probably remember this from the Talbot, Peter Talbot's lecture. Anyway, dopamine, it actually inhibits prolactin, and by inhibit, wait, did I get this agonist and antagonist wrong? Oh, I might have typed it wrong. Did I type it wrong? Oh, anyway, just bring your attention to that anyway. Okay. This is probably a very distinction question. Not high yield. You probably won't know it. I did not. A? Wow. Yes, you're right. A. This is just very hard facts. I cannot tell you why. But just know of MPP plus. Okay. Tremor while doing simple task is also known as like intentional tremor. It is a type of essential tremor. So the answer is actually a lot of people got this wrong. Here, a lot of people chose familial Parkinson's tremor. So don't be thrown off by the fact that relatives also have the symptom. The main problem is that there's no tremor at rest. So Parkinsonism, there's tremor, constant tremor. Okay. Yeah. Okay. Neuroanatomy, basal ganglia, indirect pathway, which one is correct? Very hard factual stuff that they will definitely test you on. B. Animal. You must know this diagram from your heart. Like, Very important. I cannot stress this enough. A, B, red, A, yes, A. So just basically keep drawing this diagram and you'll just get the hang of it. This is taken from the lecture. I combine the lectures and also bare neuroscience. Basically, this is the indirect pathway. It's longer. It goes to GPE and then STN and then GPI. Direct pathway, striatum, GPI, and the thalamus. You should also know, so I highlighted in red lines, these are the inhibitory neurons by GABA, neurotransmitter. The stimulatory neurons, most of these are by most of these are not dopamine, they're just at the striatum. Yeah, just make sure you know these. Glutamate. Okay. True or false? True. Yes. Very factual stuff. Now let's go to the pharm stuff. First generation antipsychotic, haloperidol. Oh, very quick. Yes. These olanzapine, risperidone, clozapine, all these are atypical antipsychotics, second generation antipsychotics. So they are the newer generations. Haloperidol, chlorpromazine, well, that drug are the first generations. Okay. Second generation antipsychotic needed. So first of all, pick the second generations. And then which one could be given as a depot? I hope you understand what this depot is. A. A, A, A. Yes, you're all right. Okay. So as I said, you need to know how to differentiate first generation and also second generation antipsychotics. Depot, from what I understand, is that you will put a very large amount of the drug, possibly sometimes subcutaneously or something, where it will be slowly releasing into the body, into the systems, so that you don't have to give it so frequently. So this is very good if the patient is not compliant. Can't you also give olanzapine as depot? I basically copied this from I got an answer from Frank and Dell. I double checked it before. There's a table. I probably should not waste too much time, but there is a table, Frank and Dell, antipsychotic, depot, here. Haloperidol can be given as depot, but it's a first generation. Risperidone, depot. Olanzapine, where's olanzapine? Anyway, you can just search on your own. I won't waste too much time, sorry. Yeah. Okay. Which drug has highest risk of, okay, A, close, yes, very dirty drug. Agranulocytosis is possibly lethal because I hope you understand what this means. Granulocytes, like neutrophils, A, so there are no neutrophils. So neutrophil and also the other granulocytes are lower than normal. So the patient is very susceptible to infection. So very dangerous, very dangerous situation. Common side effects of atypical antipsychotics. Weight gain. All? Very smart, Sophie. Okay, yes, all. Acute interval prolongation is particularly important when you reach geriatric medicine. Yeah. Okay, so how about this? I think I put it in the Google form. Let's just directly look at it. Here, ATO midday. Okay, don't be intimidated by this very long question. So malignant hyperthermia is a very important severe side effects and very clinically relevant. So you must know about it. You need to know what drugs can cause it. You should know about slightly the mechanism, which is including the iodine receptor. And yeah, that's basically it. However, yes, okay, endo cannot cause hypothermia from many resources. You might be right. However, first, we're trying to give general anesthesia. Nitrous oxide is not really used commonly. Second, the question is just testing you if you know what anesthesics are volatile, inhaled, basically. So apart from atobidate, all of these anesthesia are all inhaled. So this is the only correct answer. So as I said, don't be intimidated by very long questions. It's just basically asking which anesthesia is not inhaled. And is gas not volatile? Well, I might be wrong. I don't know. I did not really check after my exams again. So you might be correct, Mohammed. Please read up, and if I'm wrong, please tell me so I can tell everyone else. Yeah, I thought volatile means it's easily inhaled. But anyway, at least I drew your attention here. Okay. Continue. 53. False, true. True. Yeah, true. Methodium affects the succinylcholine. These drugs can cause malignant hyperthermia. Very important side effect to know. Where is the ryanodine receptor found in? So we're moving on to the muscle contraction stuff. C. Yes. You should also probably know like the whole pathway. I'm not sure if I included in my Google Drive, but then like calcium induced, calcium release, all those stuff you should probably know about. I recommend reading Guyton on this. Guyton in whole, there's a chapter. 49 or something. Yeah. Okay, let's continue. Oh, by the way, my pharmacology, I just got like 80 something percent. So I'm not always right. So if I'm wrong, please tell me. And for this question, I'm actually not sure. I later asked a friend who did a major in pharmacy, and he said nitrogen oxide. So if this answer is wrong, don't blame me. Blame that friend of mine. C. Okay, C will not. C, as I said, lidocaine. Very little side effect. Like, well, the side effects are very mild and very not risky at all. And we're giving it, if we give lidocaine, it's a local anesthesia. We won't cause systemic symptoms. So C should be the one automatically off your list. Pain relief, propofol. You won't put the patient to sleep. We're asking, well, too much in A&E. Well, I don't know. But anyway, that's what my pharmacy friend said. Nitric oxide, just know about it. Anyway. Okay, BSS. I thought they don't use nitric oxide. I really don't know about this. So my role in this question is mainly to draw your attention. So I can't promise that I got this question right. But I do promise that I got this question right. B. Yes, helplessness. So I just made a hunch in exams. So according to Wikipedia, pain catastrophizing, rumination, magnification, helplessness. I don't know why they never teach us BSS in lectures, but they somehow expect us to know about BSS. Don't ask me about BSS. I don't recommend revising BSS until the very last minute. I'd rather spend more time making sure that my physiology, anatomy, pharmacology, and pathology are put into long-term storage memory. And then for BSS, I just basically skip through YAFA at the last minute. So I still have some short-term memory. Okay. 57. Hey. Yeah. Of course, D is all right. Yeah, A. No explanation needed. This one. Cognitive behavioral therapy. That's CBT. B. 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 Okay, I might be wrong. I put magnification, but oh well. At least you know. EBM. Okay, I think we might finish on time. True. Yes. So basically, external validity is that you can summarize the results from a study and put it generally into other situations. Okay, anatomy. They put the anatomy questions at the very back, at the very back. Last few questions are always anatomy. Yeah. Yeah. Okay. Here. Trochlear nerve. So things that you actually must know first is that its nucleus innervates contralateral superior oblique muscle. That's the only thing that it does. It's also mentioned in your lecture, supposedly. So even if you don't know the other things, the pathway, how it runs, you should at least know the correct answer. So let me just explain why these others are wrong. Decussates after leaving brainstem, no. It does decussate, but it decussates within the brainstem after leaving the nucleus, but still within the brainstem. It leaves the ventral midbrain, that's true, just caudal to inferior colliculi. How it's cranial. Nucleus is at the level of inferior colliculi, not superior. Exits skull through jugular foramen. I'm surprised that 10 got this, chose this. Jugular foramen. You should very important things to know in anatomy is that you need to know all the foramina of the skull. You need to know what structures pass through it. And the jugular foramen most definitely does not receive the trochlear nerve. Okay. Let's continue. Whoops. One sec. I just got locked out. One second. Wait, why can't I share screen again? Sorry, I promise I'll end on time. Just bear with me. Any questions up till now? Okay, let's continue. Any questions? No? Okay, regurgitation of food, horse cough, which nerve is damaged. This is just very OSCE things. Vagus, yes, probably. And like when you hear coarseness, so probably like recurrent laryngeal or stuff like that. Causes regurgitation of food. Yeah. Which sinus strains into the middle nasal meatus? A. Yeah. Here there's a table that I also made. It's also in the Google Drive. Just feel free to check it out. Very important things to know. Yeah, and also know that the ostium know of the ostium. So okay, anatomy. Let me actually show you instead of since we don't have Kahoot anyway. I'll just directly show you like this. We could just discuss instead of just choosing. don't bother screenshotting because you will have the Kahoot to practice anyway. So what they did in exams is they gave us so many of these choices, which I somehow memorized. Which medical students somehow memorized, and they keep asking you which of the following. So I did not know actually about this. So if you got this wrong in the pre-mock quiz, don't fret too much. But I did get this right by elimination. So bipolar cells, what do they release? What molecules do they release? Anyone? Glutamate? Any more? Let's talk a bit briefly since we have some time. So bipolar cells. Basically, this shows everything. So the rods and cones, they release glutamate, and on the bipolar cells, there are either ionotropic or metabotropic receptors, and then they further convey the signals by glutamate receptors. There are also a very special type of cells. Okay, bye, Sophie. Thanks for the participation. Okay, there's also a type of cells, the intrinsically photosensitive retinal ganglion cells, iPRGCs, and they contain melanopsin, and they're involved. Well, you need to know of this thing. Well, it's not really relevant clinically. Well, it's relevant clinically. Anyway, know of these. So, which cell mainly release GABA? Obviously not A and B. Some improving sleep, yeah. Okay, cone and rods, they release glutamate. Ganglion cells, I just told you. Pigmented epithelium, well, why? And then that leads to these cells. So Mueller cells was the thing I did not know about. Horizontal cells, however, you should know, and that just leaves endocrine. And so that's it. Melanopsin, I just mentioned, is ganglion cells, the iPRGCs. And then G protein coupled metabotropic receptors. They are the on bipolar cells. Why? Let's see. Anyway, okay, I will spend too much time here. I can't explain further. Just remember, all bipolar cells are metabotropic. Off bipolar cells are inotropic. That's how these on and off cells give different effects. Yeah. Let's continue. I should have typed this out. Anyway, do I have a good resource or video explaining on and off bipolar cells? I do not, unfortunately, because I read books. Actually, I've covered most of the questions already. So if you guys want, I'll share with you how I prepared for exams, what resources I used, how to spot, how to use questions, and all those. If you're not interested, you can feel free to leave. And I just make sure that you have filled in the pre-mock quiz because I will send out another post-mock quiz with the rest of the questions there for you to have a try. And also, after filling in the post-mock quiz, I'll give you the PowerPoint, also the Kahoot links. Okay, anyway, let me share with you what I did in semester 3. So I'll share this Google link out first. Share. Copy. Okay, this is the Google Drive. Okay. And if you go to the UK preclin resource, there's this recommended guide for semester 3. So it's probably too late for you to start from scratch, but as a good reference, if you have something that you don't understand, definitely Neuroscience Exploring the Brain by Bear. Mark, okay, this is a very good book. If you fancy something more standard, you can read Guided and Whole. Anatomy workbook wise, I wouldn't spend too much time because they only test you in what's in your online anatomy workbook. So anything apart from that, they will not test you. The grays and moors are just good for clearing concepts and also giving you some pictures. Don't use Cooper and Clark actually. Now that I go back and think about it, it is not worth it your time because, as I said, anatomy, physiology, and pathology are the most important things. So pathology-wise, I would recommend for the few diseases like Parkinson's, multiple sclerosis, read Robbins and Cotran. Did I put it here? Robbins and Cotran. It's just like a few chapters very quickly, and you'll understand a lot. Those are actually quite high yield. I didn't do it, which was why I just got like 70-something% for this, for pathology, unfortunately. Yeah. So that's the book stuff. And then for BSS and EBM, just go read YAFA before exams. I also found some exam questions. I'm not sure if they are real exam questions or not. In the YAFA Dropbox, you can go check this out. I did this as well before exams. Yeah. So basically, that's what to expect. Let's see. And sorry for depression. What was the rate of relapse? 90% within 3 years, according to the lecture. Yeah. And by the way, yeah. So just make sure that you fill in. I haven't closed this semester 3 mock quiz yet. And yeah, just make sure you fill this in so that I get your correct email addresses. Some people did not fill in the correct email address, so I cannot send you the feedback form, and I will not be able to send you the PowerPoint and stuff like that if you did not fill it in. How do you get the pre-mock quiz? How do you come here? If you did not fill in the pre-mock quiz, how can you, like, oh, I don't understand. Okay, I'll send it out again. Will you get the reading lists? The recommended book list is in the Google Drive, which I just sent out. And the slides, I will share it out after you fill in the feedback form. You don't have to necessarily use your university mail. Just give me a email address that works. Because some of the email addresses don't work, and I cannot help you if I cannot help you because I don't really know how to contact you otherwise. Yeah, so basically that's it. Do you have any questions? I'm happy to stay for another like 5 to 10 minutes in case. But if not, Merry Christmas, Happy New Year, and good luck revising. Where are your pharmacology notes? My pharmacology notes, I did not upload those. I don't mind sending it out, provided that you fill in the feedback form. I have not created the feedback form yet because I was too busy. Sorry, but I will send it out to the email addresses that have filled in the pre-mock quiz. Yeah, okay. See you. You're welcome. Good luck in exams. Oh, by the way, don't tell the faculty. Although I'm not at Manchester anymore. Yeah, If you think this is useful, just please fill in the feedback form. That's all I ask. See you. The feedback form has not been sent out yet because I have not made it yet. Too busy, sorry. How did I prepare for the progress test? I did not prepare. Oh, wait, let me show you. Progress tests. I actually got 100% in the neuro part or the progress test because so my reasoning is just focus on your semester test because progress test in preclinical years do not count anyway. So there's no point, and you don't know anything anyway. So and other people don't know as well. So it's fine. Just revise what you've learned in your semesters. And if you have time, you can revise the semester 1 and 2 as well if you want to prepare for progress test. Focus on the clinical stuff. For example, cystic fibrosis, 1 in 2,500. It appeared twice in. It appeared in 2 progress tests. Also, know about the live vaccines. It also appeared in 2 progress tests. There was also one that asked about which ion, like calcium, potassium, sodium, which causes constipation. Well, yeah, all these stuff you should know, but like you will gradually pick up when you learn. Yeah. Any other questions? If not, you can feel free to leave. See you. Bye. Welcome. Bye. Okay, I'm ending. I go. See you.